Okay, thank you. This is one of my favourite topics, and most people find it quite complicated, and I'm going to try, if I can, to simplify it as much as possible for you, because actually I think it's just pattern recognition, and I think what you really need to do for the prenatal diagnosis of skeletal dysplasia is be patient and have a structured approach to the diagnosis, and that will take you a long way towards making a definitive diagnosis. And again, I'm going to plug cell-free fetal DNA again because that's my favourite topic too. Increasingly we're now being able to make the diagnosis on maternal blood, and with some of the gene panels that we're developing, I think we'll be going even further very soon. So, what are the objectives? Why, when we're scanning, looking at a baby who might have a skeletal dysplasia, what are our objectives? Well, our main objectives are to improve the prediction of the outcome, and in particular to determine whether it's lethal or non-lethal, and if we can, to determine the degree of handicap. And in the main, the handicap here we're talking about is one related to short stature, because the vast majority of fetuses with a skeletal dysplasia will have a normal intelligence. So what we're doing is we're informing accurate prenatal counselling and also informing further investigations. And in some instances, I think we can, as I've just explained with campomelic dysplasia, come very close to making a definitive diagnosis based on our ultrasound findings. And the other thing is that a number of parents still decline post-mortem, and so our findings in the ultrasound clinic can provide information in lieu of a post-mortem. And as I will show you, the inheritance patterns are very broad and varied, and it is quite important, I think, for us to go as far as we can towards getting some idea of what the recurrence is going to be for parents in order to advise parents of future pregnancies. So, what are we going to look at? We're going to look at the sonographic features, and we're going to consider those first of all in terms of the long bones. So we need to think about how long they are, the pattern, the growth and the structure. We need to think about the skull, whether it's a very useful sign here, whether it's mineralized, well mineralized, not mineralized, what the skull shape is. In terms of the chest, we need to look at the shape of the chest, the size of the chest. We need to look at the ribs and the structure of the ribs and the shape of the ribs. And then we need to look at the rest of the baby because there are a lot of other features which can give us a clue to the underlying pathology, some of which you've already heard about today. So in terms of looking at the long bones, what features should we be looking for? Well, we need to look for the degree of shortening. So is it minimal? Is it moderate? Or are they really, really very short bones? Again, the pattern will help you make a diagnosis. So is it rhizomelic, so predominantly proximal shortening, mesomelic, all bones short, or are the upper limbs affected and not the lower limbs, or vice versa? Is there any fracturing? If so, where? And are the epiphyses, look closely at the epiphyses to look for stippling. So the bones may be short, but look closely for stippled epiphyses, a very good clue to the underlying pathology. The chest, as I've already mentioned, is can give you very useful clues, particularly in terms of viability. So we need to look at the size of the chest. And my favourite way of looking at that is basically to look at the cross-section of the thorax compared with the cross-section of the abdomen in the same fetus. We can also look at it in a longitudinal plane here, and you can see the bulging abdomen here in this baby with a slightly but not terribly small chest. And here again you can see the shape of the ribs, and these ribs curve in and then curve out a bit, and they're a little bit short. And then you can look at the ribs in this plane too, and you can see that these are beaded ribs. The shape of the skull gives you a very good clue whether it's in the first trimester here, an abnormal skull shape, or later in pregnancy here with a cloverleaf skull. And also the profile. The profile is a very useful clue, either looking for frontal bossing or for micrognathia. And the degree of mineralization. Is a good acoustic shadow cast by the skull, or is it not? Can you see the intracranial anatomy more clearly than you would expect to? The spine too can give you good clues. So look at the mineralization of the spine, and here you can see there's virtually no mineralization of the vertebral bodies. Here you can see the spine looks a bit disorganized, and this is because of multiple hemivertebrae and indeed missing ribs in association with the abnormalities of the vertebral bodies. But so this looks like a slightly disorganized spine, as indeed do these spines here, but these do not have hemivertebrae. These spines look disorganized because of additional calcification. These babies have achondrodysplasia punctata. The presentation of skeletal dysplasias varies with gestation, so an increased nuchal translucency is not infrequently found in association with skeletal dysplasias. Clearly you can see short limbs, but you can also see other features. And I would put it to you that in the early pregnancy, sort of in the first trimester, that visualizing the limbs, particularly the hands and feet, can be very good. You can see them very clearly, and you can get some very good clues, as I'll show you in a minute, to the presence of an underlying skeletal dysplasia. In the second trimester, very similar presentations, but the most common presentation, of course, will be that of a short femur, because that's what we measure routinely. And in the third trimester, then babies with skeletal dysplasias will often present with polyhydramnios, with short femurs, and you can, of course, detect other features, as we'll come to later. So clearly, the type, the exact skeletal dysplasias that we detect will vary with gestational age. In the first trimester, you're more likely to pick up those which might be lethal, but they are not uniformly lethal. So because you pick it up in the first trimester does not mean to say that it is lethal. The second trimester, you pick up, obviously, all those that you might see in the first trimester, plus a few more, which have a slightly less severe phenotype or less early onset. And in the third trimester, of course, the commonest skeletal dysplasia that you're going to pick up there is achondroplasia, which does not have a shortening of the limbs before 24 weeks. So let's think first of all about the first trimester, because we're increasingly doing detailed scanning in the first trimester. So what are the clues to skeletal dysplasias here? Well, increased nuchal translucency or generalized edema. Head shape can be also a useful clue, as can the degree of mineralization of the skull, and also the presence of anomalies of the hands and feet. So the commonest skeletal dysplasia that we see is thanatophoric dysplasia. This is uniformly lethal. And it does present early in pregnancy, and I know that we are currently picking it up relatively frequently with our combined testing. And you can see that you can have an abnormal skull shape. The frontal bossing is present in the first trimester here. This 3D view here shows very nicely the frontal bossing, but also the increased nuchal translucency, which you can see there and there. Even in the first trimester, you can see the slight bowing of the femur in this fetus, which has got the classical telephone receiver shape of the femurs. Remember, not all skeletal dysplasias have that shape. Some of them are short and straight. And again, you can see how short the ribs are. So here's a cross-sectional through the fetal thorax, and you can see the ribs end here. And this is the abdomen, the same fetus, and you can see how much smaller the abdomen is than the fetus. And again, here's another case where you can see that the heart appears to be protruding here because the ribs are very short. Osteogenesis imperfecta, again, there are a number, as I will show you in a minute, of types of OI, but the severely lethal sorts, 2A and 2C, are readily detectable in the first trimester, both because of a completely sonolucent skull. You can see beading of the ribs even at this early gestation, and the limbs are short and crumpled. Dystrophic dysplasia is not a lethal condition at all. It's completely viable, but the clues to the presence of this in the first trimester, when you look at the baby's hands, and you can see this is the abnormal positioning of the thumbs here. So these babies all have hitchhiker thumbs, so that their hands always look like this, and hitchhiker toes. And if you see that sort of finding, it's worth measuring the limbs, look closely for talipes and other things, because they can be clues to the underlying diagnosis. Ellis van Creveld, again, is another condition which is not uniformly lethal. And again, it's polydactyly, which might give it away in the first trimester. And then if you look closely, you may see short limbs, and you can sometimes also pick up a heart abnormality. So I'll just emphasize the importance of pathology here, because the recurrence risks are very different from these different conditions. And making a diagnosis in the first trimester, it's very tempting to offer people surgical terminations of pregnancy, and indeed many women, that's what they want. So thanatophoric dysplasia is uniformly lethal, but it's a new dominant mutation, so recurrence risks are very low. Similarly, with osteogenesis imperfecta, it's universally lethal, types 2A and 2C, and it usually has a very low recurrence risk, so we'd usually quote them about a 3% recurrence risk. Ellis van Creveld, on the other hand, is autosomal recessive and has a 25% recurrence risk, as does dystrophic dysplasia. And then there are a whole host of others, short-rib polydactyly syndromes in particular, which I think is probably the main differential diagnosis for something like thanatophoric dysplasia, achondrogenesis, etc., have higher recurrence risks. These have a 25% recurrence risks. So making a definitive diagnosis is very important for parents in future pregnancies. And again, here we go, cell-free fetal DNA can help you here. And as I said, we already have heard about the properties of cell-free fetal DNA, so I'm not going to go through that again. But certainly in our laboratory now we have developed cell-free non-invasive prenatal diagnosis for thanatophoric dysplasia, and we can detect this condition is due to many mutations in the FGFR3 gene, all of which are detectable by our next generation sequencing panel for FGFR3. And of course, if you can take mum's blood and make a definitive diagnosis in the first trimester of thanatophoric dysplasia, then that will allow her to have a surgical termination of pregnancy. And we also find it very useful in twin pregnancies where there's a discordance for the skeletal dysplasia and a normal baby, because you can again make the diagnosis on blood. And so it allows for a safe diagnosis and non-intervention in those situations. So I think in the absence of a molecular diagnosis, one of the messages I would like to try and get across today is that in the first trimester we should avoid a surgical termination of pregnancy if possible, because expert perinatal pathology is required. And I haven't gone into this, but I do emphasise the word expert perinatal pathology. Not all babies with short limbs have got achondroplasia, for example, so you do need expert attention here. So in the second trimester, the most common presentation for skeletal dysplasias is, of course, a short femur. And we're going to think about this in terms of whether the short femur is isolated or whether there are other features or not, and what the patterning of shortening is, whether there's any bowing, and the chest size, the skull size, shape and size, etc., and the spine, as much as we have done in the first trimester. Now, I'm going to, again, take you through some work that we've done at UCH, looking at cases that we've had to give you a sort of structured approach to the diagnosis of these conditions. So here what I've done is I've taken a series of babies that were referred to UCH with apparently, the referral said, isolated short femurs. And I've divided these into short straight femurs and short bowed femurs because the etiology is different. And when we looked closely at the cases referred, then of those referred with isolated short femurs, only 42 were in fact isolated, and 21 had other abnormalities. And if we think about the isolated ones now, clearly the first thing we do when we see a baby is measure it carefully, and 20, when we remeasured them, were normal, and 22 had generalised shortening. And of those, only two had a skeletal dysplasia. 7 had constitutional short stature, which emphasises the need to look carefully at the parents and to do serial scanning to make sure that these babies are growing, their limbs are growing at a normal rate, albeit at a line maybe below the 5th or the 3rd centile. The majority of these babies with isolated short femurs, in actual fact, had IUGR. And so the management, when you're looking at babies in the second trimester, and I'll be reiterating this for the third trimester as well, with apparently isolated short femurs or short limbs, is to take a careful family history to exclude a history of intrauterine deaths, preeclampsia, or a previous abnormal baby, to look at the parents to exclude constitutional short stature, and to review the Down syndrome screening results, because that may well give you a clue, if the biochemistry is abnormal, towards the underlying potential IUGR. Remeasure, as I've said, check the dates and that sort of thing. And look at the pattern of limb shortening, the size of the head and abdominal circumference as well. And again, make sure you've decided whether they're bowed or straight. Do a detailed scan for markers of aneuploidy, because clearly short femurs can be a marker of aneuploidy, but not usually in isolation. You would normally find some other marker or biochemical marker indicating that. And then I think you should do Dopplers. You should certainly do the uterine artery Dopplers at this stage to exclude the possibility of impending IUGR. And of course you should consider karyotyping if this baby is generally small. So the message from this part of the presentation is one of the most common presentations, etiologies of short limbs or short femurs presenting in the second or indeed the third trimester is IUGR. So please remember to think about early onset IUGR. I see all the babies with skeletal dysplasias in our unit, and a significant proportion of those cases that I see with short limbs are in fact growth retarded babies. What about isolated bowed femurs? So let's think about these 22 here, which had an isolated bent legs. So 15 had a unilateral anomaly. Most of those continued with the pregnancy and had live births. They were isolated anomalies in 13 of the cases. My sums don't add up. There was one case of femoral hyperplasia, unusual facies syndrome, which you're not going to pick up. You're not going to pick up the unusual facies with ultrasound. What about those with bilateral, so bilateral bent femurs or bent legs? We had 7 cases. 2 of those were asymmetrical, and again, these were just isolated anomalies with no particular genetic etiology. One continued and one terminated the pregnancy. And 5 had symmetrical bent legs. And of those, 3, I think, had osteogenesis imperfecta type, no, more than that, 4 had osteogenesis imperfecta type 3/4. And I think this is a very very important to remember that the bilateral symmetrical nature of this may indicate an underlying skeletal dysplasia. And the 2 skeletal dysplasias that you need to be thinking of predominantly are OI type 3 or type 4. And here you can see the bowing of the legs here. And this is a normal profile here. And you can see the growth. Type 4 can be very, very subtle, and I'll show you that in a minute. We have relatively normal growth of the long bones and just minimal bowing. Type 3 often has shortening of the humeri and other long bones, and can indeed, as pregnancy progresses, have shortening and bowing of all long bones. Campomelic dysplasia, as I mentioned in the previous talk, can have bowing of the lower limbs and talipes. It can have genital ambiguity here and sex reversal, and it can also have micrognathia. So this just summarises the difference here, but I think you can very readily distinguish between OI and campomelic dysplasia. The OIs, of course, are very serious conditions where even the OI type 3s end up, many of them, some of them are perinatally lethal, and they have progressive fracturing throughout childhood. But the fracturing actually, with treatment with bisphosphonates, can be ameliorated, and it is worth talking to your paediatric colleagues and getting them to counsel parents under those circumstances. But campomelic dysplasia, it's due to a mutation in the SOX9 gene, and here you can see again SRY showing that this has got genital sex reversal here, and helping you make the diagnosis, and this has got a low recurrence risk. As I said to you, type 3, type 4, so this is the bowing in a baby with type 4. We have 2 of these cases now, very subtle bowing of the femurs and actually the tibias as well. Type 3 tends to have more severe bowing, and as I said, it can have associated associated fracturing of the arms as well, and often has fractured ribs at birth. This is so this is type 4. The growth of the long bones in type 4 relatively normal. The growth of the long bones in type 3, you can see that the length of the long bones in this series of cases falls below. It's variable, but falls below the centiles from about 22, 23 weeks onwards. A bit much to take on probably, but you can see here that the difference in the presentation of OI type 2A and type 2C, which are uniformly lethal, have very small chests with beaded ribs, very short crumpled long bones, and hypermineralization of the skull. Type 2B is also perinatally lethal in a significant proportion, but not all cases. It can have some degree of hypermineralization, as I'll show you shortly. It can have, definitely has flared ribs, and it does have short, but not so short, and bowed long bones. And type 3 and type 4 we've just seen. I'd like to just emphasize the fact that when you're talking to parents about osteogenesis imperfecta, they all go home and hit the internet. I think it's very important that you define the different sorts that you're discussing so that they don't get confused. The gestational age of diagnosis for OI, of course, varies considerably. Type 1, which is the autosomal dominant type, very rarely presents in the third trimester, if at all. This is the type which usually presents in childhood. Children have blue sclerae and can have variable presentation and variable degrees of fracturing, and there's a 50% offspring risk here, but it's not something you're going to be able to pick up on ultrasound. Type 2A and type 2C, we just explained, are lethal, and you can pick them up very early in pregnancy, as you can for type 2B. Most type 3s I don't think you're going to pick up until a bit later in pregnancy, although we have seen a few earlier now. And type 4, I think type 4, 5, 6 and 7 and 8 are much more less severe, and really we may not pick up until later in pregnancy. Now, what about looking at the epiphyses? So some babies have short femurs and stippled epiphyses. So if you look, this is a stippled epiphysis here. And this really does narrow down your diagnostic range. These occur as part of the chondrodysplasia punctatus, of which there are a number. So here you can see the prenatal X-ray here, the prenatal ultrasound here with the stippled epiphyses. Postnatally, you can see this extra calcification at the epiphyses here. The spines, as I explained earlier, can often look disorganized, and they're disorganized because of the extra calcification. In this case here, you can see extra calcification in the hand here, and you can see it here and here. These are serious conditions. Most are metabolic, have a metabolic etiology, and there's a variety of different metabolic etiologies. It can be seen in association with maternal warfarin ingestion. It can also be seen in association with maternal hypothyroidism. This case actually was a case where the mother had unrecognized congenital hypothyroidism. Peroxisomal abnormalities, disorders of cholesterol biosynthesis, etc. Many have a very poor prognosis. Not all, but many have a very poor prognosis. They can be X-linked or recessive, and they therefore have relatively high recurrence risks. And you really do need to call upon your genetics colleagues here to help with the diagnosis. But it's the sort of situation that somebody once phoned me and said, Lynn, I've just looked at this baby. It's got no nose. It's got a funny-looking spine, and the limbs are a little bit short. So I said, well, I think it's got chondrodysplasia punctata. Look carefully at the ends of the bones, and of course, there you are. It had stippled epiphyses. So no nose, funny spine, think CDP. So they said, it's a funny spine. It's not hemivertebra, and it's not spina bifida, and I don't quite know what it is. So look carefully, because it's the extra calcification which gives it this irregular appearance. Okay, so let's think, going on with our logical approach to the diagnosis of skeletal dysplasia. So here we have a baby with short limbs and a small thorax. So what are we going to think about? Well, the most common condition is thanatophoric dysplasia, followed up by osteogenesis imperfecta and some of the short-rib polydactyly syndromes. And I'll just show you a few pictures here. So thanatophoric dysplasia is the most common condition, and pathognomonic really is this frontal bossing here with a very small chest. You see the frontal bossing here, often with polyhydramnios, and short, stubby fingers. If you can get to see the fingers, then short, stubby fingers. The ribs are short, but they're straight. There's no beading, and whilst the femurs might be slightly bowed, the other long bones are straight. There's no crumpling. They're short and straight, the other bones, and the chest is much smaller than the abdomen. This is I think it's a relatively, if you think about the pattern here, this is common, and it's relatively straightforward to make the diagnosis. The short rib polydactyly syndromes are a group of different syndromes, all of which are inherited in an autosomal recessive fashion. This is what it's like when you see these babies. They're always in difficult positions and you can't get good pictures. So this is the only one that I've got really good pictures of, and this is a case of Majeski syndrome, where it has preaxial polydactyly, and you can see the duplicated thumbs here and the great toes here. It has a small chest and short ribs. They can have a variety of other abnormalities, all sorts of intracranial abnormalities, all sorts of, some of them have facial clefts, and this is, you can see the very small cleft here, and you have to believe me that this arrow here is the best view we could get of the upper lip here. And they have a variety of urogenital abnormalities, both renal tract abnormalities and external genitalia, abnormalities of the external genitalia. They are lethal and they are autosomal recessive. So again, a variety of abnormalities. The differential diagnoses are things like Meckel-Gruber syndrome, possibly trisomy 13 as well, and Smith-Lemni-Opitz. So you do need, but then apart from trisomy 13, these are all recessive conditions as well. Jones asphyxiating thoracic dystrophy can also present with slightly less short limbs and a slightly small chest. It can be much more difficult. This chest really doesn't look too bad, and indeed more than 60% of babies with Jones will survive the newborn period. You can have polydactyly with Jones syndrome. You can also see cystic kidneys, but I personally have never seen cystic kidneys in this condition, but they do get renal dysplasia with age after birth. This is also autosomal recessive. I think it's very easy to look at the longitudinal view of a fetus here. You'd think this baby here, bulging abdomen, small chest, champagne cork sort of appearance, but not quite, has a small chest. But in actual fact, it doesn't have a small chest, and this emphasises the need to look in a transverse plane when you're looking at the size of the chest, as well as in the longitudinal plane. So this baby has normal length ribs and a normal chest. It has a short chest here, or apparently short chest here, because it's a short spine. This baby has spondyloepiphyseal dysplasia congenita. It's viable. Survivors have completely normal intelligence. They have very short stature. They're shorter stature than achondroplasia, but nonetheless, they are intellectually normal. They have short, straight limbs, and they have normal hands. So if you look at them compared with a baby with thanatophoric dysplasia, their finger length is normal, and you'll see here that they can have micrognathia, and there's no frontal bossing. These are autosomal dominant conditions due to a mutation in the collagen disorder gene. Again, I would re-emphasise the need for definitive diagnosis because of the variation in recurrence risks, so varying from less than 1% for new dominant mutations in thanatophoric dysplasia to 25% for something like Jones asphyxiating thoracic dystrophy. And of course, for SEDC, which is a dominant condition, there will be a 50% offspring risk to the person with SEDC. Hydrops is another very useful clue. It's often very difficult because the degree of hydrops can be really extreme in some of these conditions, so it's very difficult to define the underlying abnormalities. So this is one baby that I saw many years ago now with a horrible looking brain, and all you could see, there was so much polyhydramnios, you couldn't really get a good view at all. Huge bright kidneys and very distended abdomen with this gross ascites. So this baby had short ribs, it had a tiny, tiny chest. You could hardly see the ribs. This is autosomal recessive, and it's something called Ehlers-Danlos syndrome. Greenberg dysplasia is another one of the chondrodysplasia punctatas. Again, gross hydrops here, and a tiny, tiny chest. And here you can see the ascites here. Again, many of these conditions are going to be recessive, so it's very important to get a pathological diagnosis. The other common-ish finding with short limbs is hypomineralization, and these really are the four conditions which you need to be thinking about when you have hypomineralization. the commonest of which is going to be osteogenesis imperfecta. We've talked about that before. So these are the severe sorts, the type 2A and C, where you often get a referral with query ventriculomegaly. And the reason why it looks like the baby has ventriculomegaly is because you can see the inside, the intracranial anatomy so clearly, because there's virtually no mineralization of the skull and no acoustic shadow cast. These have very small chests, as I've said, with beaded ribs and very short, crumpled bones. They're mostly due to new dominant mutations, and the recurrence risk is low, between 5 and 7%, because there are some recessive varieties, and germline mosaicism can occur. The other rare condition, they're all rare, all of these are rare, association with profoundly hypermineralized skull is achondrogenesis, and you can differentiate that from osteogenesis imperfecta by looking at the skull, at the spine here, and you can see this railroad appearance due to the hypomineralized vertebral bodies, which you can see very clearly on this postnatal X-ray here. And finally, you can also see the difference in the limbs. So these limbs are in achondrogenesis, they're very short and very straight, whereas in osteogenesis imperfecta, they are very crumpled. So you often can't really make out with the limbs in OI, very crumpled due to multiple fracturing. And in all of these conditions, the foot length is maintained, and that's was always amazing, really. Achondrogenesis type 1 is another recessive condition, so we need, again, to make that definitive diagnosis. Just to go back to OI, so OI type 2B has variable mineralization of the skull. You can usually see rib fractures, and in the transverse view of the thorax, you often get this appearance of the ribs where they sort of bend in and then bend out a bit because of fracturing. It's very pathognomic, really. And again, they have bowing of the limbs. They can have some quite severe angulation, but they're not as crumpled as in 2A type 2C. And this can be perinatally lethal, but they can also, babies with this condition can survive, although they have severe respiratory problems. Then there are other clues to underlying skeletal dysplasias, namely polydactyly and syndactyly. And we need to think of, if you see that, we've already thought about some of the conditions, but here's Ellis van Creveld, again with preaxial polydactyly here, a slightly small chest, but this is a viable condition. It's recessive, and they can have smallish chests, so there can be some respiratory difficulties. They often have heart abnormalities, but this is not usually a lethal condition. The other thing you might see is the mitten hands of Apert syndrome here in 2D or 3D, when you need to look then at the skull to look for craniosynostosis or proptosis here. This is a dominant condition, again, which we can make the diagnosis by on mum's blood by doing cell-free fetal DNA analysis. So if we move on from the second trimester to the third trimester and think about the presentation of short limbs in the third trimester, again, it's very similar to earlier in pregnancy. Have their bones been measured properly? Has the pregnancy been dated correctly? Is there IUGR present? What's the height? What's the stature of the parents? Think about skeletal dysplasias, and also think about aneuploidy. So achondroplasia is the commonest viable short stature syndrome. This doesn't present until after 25 weeks gestation when short limbs occur. So here are the normal limb lengths here, and this is a cohort of babies with achondroplasia measured in the second trimester, all the measurements lay within the normal range, and you can see that come 25, 26 weeks, the measurements begin to fall below the normal range. These babies also have relative macrocephaly, and that occurs from early in pregnancy. And again, these are the normal head circumference charts here, and you can see the head circumferences lie on or above or around the 97th percentile for a good number of these cases. The abdominal circumferences lie within the normal range. 98% of these babies with achondroplasia have the same common mutation in the FGFR3 gene. They also have frontal bossing, so it's same gene, mutation in the same gene as thanatophoric dysplasia, so they have very similar features. It's just the chests which aren't so short and the limbs aren't so short. So thanatophoric babies' limbs will be down here. So frontal bossing here, polyhydramnios, short stubby fingers, trident hands. They can have a slightly small chest, so you shouldn't be put off by that. Many of them do have a slightly small chest, and some can have respiratory difficulty. Some can also have ventricular megaly. Some indeed need shunting after, in childhood. And they can also have slight bowing of the femora. Again, we can do a definitive diagnosis by taking mother's blood, and we have a sequencing panel now which will pick up all the achondroplasia and thanatophoric mutations. So again, the diagnosis can be made on blood, on mum's blood, on cell-free fetal DNA. So in summary, the management of short femurs in later pregnancy is very similar to what we've thought about before, but do look at the pattern of the limb shortening and look at the relative size of the head circumference to abdominal circumference. So babies with normal limb length in the second trimester, relative macrocephaly and short femurs in the late second or early third trimester, you should be thinking achondroplasia. Of course, at that stage in pregnancy, you can't always pick up the other features, so it may be worth excluding that diagnosis by analysing cell-free fetal DNA. Nonetheless, remember to look for markers of aneuploidy, and Dopplers, both fetal and maternal here, are important to exclude IUGR, which can present late. The amniotic fluid volume is often increased in achondroplasia, but not always, and may well be decreased in IUGR. Look at the parents, review the Down syndrome screening results as well, because that may give you a clue to IUGR, and consider karyotyping, particularly if you see other markers of aneuploidy. So in conclusion, reasonably accurate sonographic diagnosis of some skeletal dysplasias is possible. Now, there are many, many skeletal dysplasias, not all of which, of course, present prenatally. So making a definitive diagnosis can be difficult, but we do need to do our best if we can. Post-delivery confirmation is absolutely essential, either using molecular methods or by post-mortem and radiology, in order to advise parents of recurrence risks. Accurate diagnosis requires time and patience and specialist knowledge, and I would strongly recommend liaison with genetic colleagues. And here's my dog, Tiger, who happens to have a mutation in one of his FGFR genes, so I thought you'd like to see him. So thank you very much.
Thank you, Lynn, for sharing with us your wonderful experience in this challenging field for prenatal diagnosis. So, just take a deep breath. Yes, please. Just one hand, the same as before. Hope someone else will join the discussion. If you don't mind, in the meantime.
Professor Chetty, thanks for the very nice overview. Actually, there's a lot of discussion going on.
Silence, please.
There's actually a lot of discussion going on about the use of low-dose CT scan in skeletal dysplasia. Could you please comment a little bit on that?
I don't think it's necessary, and I don't think we should be doing it, particularly if the pregnancy stands any chance of continuing.
Any other question? Yes, Katya, our host.
It's a question a little bit on a different note, but well, you showed that a lot of these skeletal dysplasias present with increased nuchal translucency in the first trimester, and they have different pathways. Do you have an idea why they present with increased nuchal translucency?
I think if you look at them, when you look at a fetus a bit later on with short limbs, they often look like they're very fat, and it's because the skin continues to grow and the bones don't. So I think that there's a differential effect on the bone. They all have thick necks and things. So I think it's just a feature of the way they've got short necks, short spines.
So it's not an edema?
I don't think. Well, not necessarily. No, I don't think it is actually.
Okay, thank you.
Any other question? Yes, please, from Turkey.
Yeah. When you mention about short femur in the third trimester necessitating amniocentesis, would you be certain about the severity of the shortness, like you take 5% or anything between 5 to 10% is concerning?
I think If you're going to think about, are you thinking about aneuploidy in the third trimester? I think there would normally be other markers of aneuploidy. So I mean, I've only got one case where the baby had Down syndrome with presented in the third trimester, and she declined Down syndrome screening. So we haven't even got that to go back on. So I think. I think it's an isolated finding, it's a common finding, and I wouldn't necessarily advocate invasive testing. And then it also depends upon what your policy is with regard to what you're going to do with the management. And you can just do an IPT now anyway.
Any more?